and chat pod. If you have any questions during the webinar for the webinar presenters, we ask that you submit those questions into the presenter Q&A pod. There will be periodic stopping points for question and answer, and there will be a time designated at the conclusion of the webinar for Q&A and discussion with our presenters. I now present to you our webinar entitled How to Use New CDC Guidelines on Opioids to Treat Patients, and our moderator is Dr. Ann Gagliotti, MD, and she is the Director of the Southeast Regional Clinics Network at the National Center for Primary Care, Morehouse School of Medicine.
Thank you very much, Sherilyn. The next slide. I'm just going to give a broad overview of our talk today. The new CDC guidelines were put out on prescribing opioids for chronic pain based on two major issues that are ongoing. The first is the current public health landscape of opioid use in the United States and the overdoses that have been associated with opioid use disorder. Additionally, there have been some physician-identified challenges that are associated with managing patients for chronic pain issues. Based on this, the CDC has updated the guidelines that had originally been put out by AHRQ in 2012. These guidelines focus on three major areas. The first is determining when to initiate or continue opioids for chronic pain. The second is how to select an opioid, dosage, duration, follow-up, or discontinuation. And the third area is assessing risk and addressing harms of use. How do I advance the slide? So in the first category, which is determining when to initiate or continue opioids for chronic pain, the first guideline is that non-pharmacologic and non-opioid therapies are generally preferred over opioid treatment for chronic pain management. And opioids are really only indicated if anticipated benefits outweigh risks for the patient. Additionally, they recommend that treatment goals for pain and functionality should be addressed prior to starting a medication regimen, and that the doctor and the patient talk about parameters for discontinuation if the risks do end up outweighing the benefits for the patient. Also, patients should have an in-depth understanding of the risks of opioid therapy for chronic pain before they are prescribed medication, and the patient and clinician roles should be well established as far as how things will go for managing therapy and discontinuing therapy if needed. When it comes to opioid selection, dosage, duration, and follow-up, and possible discontinuation if risks outweigh benefits, they recommend that immediate-release opioids be first prescribed before long-acting or extended-release opioids. They recommend that the lowest effective dosage be prescribed. And if opioids are being prescribed for acute pain, it's recommended that patients are given a short-term supply of opioid medication. The amount of time that is recommended is 3 to 7 days. It's also recommended that after patients are initiated on opioid therapy, that they have a follow-up within 1 to 4 weeks to do a risk of harm assessment. At that time, if the benefits are not outweighing harm for the patient, it's recommended to optimize other therapies and consider a taper of opioids. The third prong of the guidelines focuses on assessing risk and addressing harms of use. They recommend that a risk assessment be done before and then during treatment as it is ongoing. And they recommend consideration of a naloxone prescription if a patient has a history of overdose, substance use disorder, or is on a high opioid dosage. Additionally, for patients who are on concurrent benzodiazepines. They recommend that providers monitor the prescription drug monitoring program for their patients so they can assess what dose of medication and other prescriptions that the patient might be obtaining from other providers. And they recommend that this be done in about every 3 months or with every prescription. Also, it's recommended that patients have urine drug testing before opioids are prescribed and at least annually afterwards to assess for use of other prescribed medications or illicit drugs. They also recommend that prescribers avoid concurrent prescribing of opioids and benzodiazepines unless absolutely necessary. And then finally, they recommend that providers offer and arrange for evidence-based treatment, namely buprenorphine or methadone in combination with behavioral therapy for patients who are identified with opioid use disorder. The CDC has put out some great tools to assist providers with implementing these guidelines, and I'll have some links to that at the end of these slides. But first, I wanted to introduce our two speakers for today. They are Dr. Nzinga Harrison and Mr. James Langford. Dr. Harrison is the Chief Medical Officer at INCA Behavioral Health, and as a physician with specialties in adult psychiatry, community psychiatry, and addiction medicine, she provides leadership and management for current and expanding services in INCA's East Coast operations, as well as serves as medical director there. She is board certified in both general psychiatry and addiction medicine. She's an expert consultant at the Southeastern Addiction Technology Transfer Center and designs education materials for primary care physicians regarding the evolution and treatment of substance use disorders in primary care settings. She has published extensively within numerous publications and has served as a keynote speaker for many conferences. She received her bachelor's from Howard University and her MD from the University of Pennsylvania and completed her residency in psychiatry at Emory. James Langford is an MBA and serves as the executive director for the Georgia Meth Project. He is well known to many elected officials and policymakers. He has been appointed by 5 governors of Georgia over a 35-year period to several statewide commissions and boards, and has a long career in nonprofit public service programs that benefit communities in the state of Georgia. He is a native of Calhoun, Georgia, and is the founder of 2 successful nonprofits, the Million Mile Greenway, an organization that helps communities throughout the eastern U.S. preserve and connect green space, and the Katsawati Foundation, an organization that concentrates its effort on the study and protection of archaeological sites in environmentally sensitive areas. He also serves as the board of counselors to the Carter Presidential Center and is a member of the Downtown Atlanta Rotary Club. He earned his undergraduate degree in journalism from the University of Georgia and has an MBA from the Harvard Business School. We welcome both of you and thank you so much for taking time to share your expertise in these areas with us. Dr. Harrison, please feel free to start.
Thank you. So I think I can drive my slides from here. Thank you for that lovely introduction. I was excited to be invited to participate in today's webinar. As a psychiatrist with specialties in addiction medicine, I have to work closely with my primary care colleagues to make sure that we're able to effectively manage patients' pain while minimizing the risk for substance use disorders to develop, and if they do develop, how to manage those two things concomitantly. So I have spent quite a bit of my career helping primary care offices integrate mental health care into their services, and so I wanted to spend some time talking about the probably most common barriers and benefits that primary care providers will face when trying to implement these guidelines. So to that end, the benefits of the CDC guidelines really are aimed to be threefold. We want to keep patients safe, that is adequately managing their pain disorders while minimizing the risks associated with the treatment of those disorders. We want to overall promote wellness, so the management of pain, preaching to the choir, I'm sure, is not just the absence of pain, but also the improvement of function and quality of life. And then very importantly, and maybe the mainstay of these guidelines, is to mitigate the risk associated with the treatment of pain disorders. And so when we look at those benefits, I think we would all agree that those are how we try to practice medicine in general. When we look at keeping patients safe, it really splits into two arms. So one, reducing the risk of opioid overdose, and so that really has been the impetus of a lot of the public sight that is on prescribed and illicit opioid use, because the number of overdose deaths is increasing dramatically right before our eyes. But as physicians, the other arm of that, so we have to mitigate the risk of overdose, but we also have to reduce the risk of substance use disorder. And so I think at this point, maybe there was a poll question. My IT folks, can the first poll question come up, which is for my participants on the webinar call. I think the question is, do you feel that you have the knowledge and the tools necessary to identify those patients who are at increased risk of substance use disorder, and if so, how to manage that? So I don't see the poll question, so we'll go to the next slide and just jump right in. The second goal, I said, really was to promote wellness. So if we conceptualize pain the same way that we conceptualize other chronic medical illnesses, it really is developed by biological, psychological, and social factors. And then also, if we want to treat it, we know that we need to intervene in all three of those spheres: biologically, psychologically, and socially. And so these CDC guidelines really do a great job of guiding us based on the existing evidence base for those biological interventions that will be helpful, and we'll get specifically into the guidelines for those. Also for those psychological interventions that can be helpful for the management of pain, and the social interventions. And certainly the idea is, if we can put a well-balanced treatment plan together that really emphasizes the psychosocial aspects of pain, that can potentially undermine the need to go to an opioid medication management strategy. So thinking of mitigating risk, this is actually developing a hostile time for physicians. So if you look at the general tenor of the public, the opioid crisis is being blamed on physician prescribing practices. I put these two examples up here not to exploit these physicians, but to show you that courts are literally bringing criminal charges against physicians that they feel like have not adequately managed the risk of their opioid prescriptions. So these guidelines come at a critical time for us to help us have those conversations with our patients, to help us increase our knowledge in those places where we need it, so that we won't be subject to the anger that people are experiencing over the rise in opioid deaths. So looking at the barriers, although I think we can all agree on the benefits that these guidelines will offer us, many times new guidelines come out and the barrier is just that I don't even know how I would begin to implement this in my practice. And so for the next few minutes, what I wanted to focus on are really the most common barriers to implementing new practices, but then also to give some specific strategies about how you may be able to address those barriers in your specific practice, whether that's an office-based practice, a hospital-based practice, or academic area or otherwise. So the three most common barriers really will be time, resources, and knowledge. And so what I did here was take the different guidelines that are kind of, in my opinion, most at risk to be falling in this barrier bucket. So in terms of time, guideline number 7 says to reevaluate frequently, that the management of acute pain with opioid methods should go no longer than 7 days and be reevaluating between 1 and 4 weeks. Well, I think it's probably common to do these frequent reevaluations during the management of acute pain. That may not be so common with chronic pain. And so this affects the time barrier, because if you don't add additional clinical time to your practice, how do you manage the additional appointments that will be necessary to meet this guideline of reevaluation every 1 to 4 weeks? Number 8 is risk mitigation. So the risk mitigation guideline, and we'll go a little bit more into it on the next slide, says, identifying those patients who are at increased use for substance use disorders, employing naloxone. And the question is, how do you float that into your existing process when there already seems to not be enough time for all of the things that you already have to do to get a patient in, cared for, and out of the service line? Number 9 is the prescription monitoring drug program. So each state has one of these. The criteria for how you access the PMDP and who can access it is different in every state. But in general, a PMDP exists so that you can look up to see if this person is maybe getting prescriptions from other sources. The pharmacies report to it. And then that can help you try to quantify the risk that this person may be abusing or at increased risk for overdose, running out early, getting prescriptions for other places, those flags that we use to identify patients who are at risk. I put this under time barrier because when do you have the time to access the PMDP? Where do you float that into your service of care? So we'll talk about that on the next slide. And then finally, drug testing. Drug testing can be particularly difficult. I had a poll question here that was, oh great, of these barriers in your practice, looks like 62% of people said the biggest barrier for implementing the guidelines would be time. So that's exactly what I anticipated. When we talk about drug testing, often, especially office-based practices, may not have the rapid drug test. So you know how we have the rapid urinalysis, we have the rapid pregnancy test. If you don't have the rapid drug test, then even when you screen that person, you don't get the results back until after they leave. And so how do you manage that timing? We'll talk about on the next page. Resources are also a definite barrier. I see here only about 17% of people who responded felt that resources would be an issue. But the first guideline says non-pharmacological therapy is preferred, right? So these are those psychosocial therapies that have been shown to make a difference. The question is, do you have a network that you can access that can provide those therapies? How do you make those referrals? How do you get your people connected? And that wraps back around to the time barrier, right? And kind of close those gaps to make sure people are able to access those non-pharmacological therapies that have been shown to be helpful, and now with this guideline have been elevated to preferred over opioid management. And then finally, offering or arranging for evidence-based treatments for opiate use disorder. So if this person comes in with an opiate use disorder, or if they develop an opiate use disorder over the course of your treatment, do you have those program relationships in place? Does your community even have an opiate treatment program? Do you have access to evidence-based treatments to be able to offer those to people? And so we'll talk a little bit about kind of how to arrange that. And then finally is knowledge. So I think, people assume that during medical school, we learned all of these things. And what we know is that kind of the identification and treatment of pain disorders, opiate use disorders, risk factor identification, many of the things that are included in these CDC guidelines, we did not get a robust expert level of training in during our medical school and training years. And so it is, how do you target those CMEs that will specifically prepare you to deploy these guidelines in your practice? So let's just take a quick walkthrough. Time. So this is the general process, kind of just like overarching process that happens when you go to a doctor's office, and time is the biggest barrier, right? So the patient checks in, they wait in the lobby, they wait in the exam room, they see the primary care provider, and then they check out. The question is, where can we float these CDC guidelines to fit into that existing process without adding so much additional time that it becomes a barrier to us being able to manage our clinical workloads? And the first answer is that we have to plan ahead for it. So when you're going to have a busy day and you're not going to have a minute to spare, you schedule it out as much as possible so you can anticipate what's coming next. That's what we have to do with the clinical process here too. And so these are just suggestions. Maybe the prescription monitoring drug plan, you can have your front desk check that as part of the check-in process for a patient that they're managing their chronic pain. So then by the time they get to you in the room, that information is already printed out for you, as opposed to you trying to sign on to the registry while you're in the room with the patient. While the patient is waiting in the lobby, we know that those patients who are at increased risk for developing opiate use disorder, so remember, we're trying to mitigate our risk in two arms, the risk of overdose, the risk of developing substance use disorder. We know that those patients who are at increased risk also have pre-existing anxiety disorders, pre-existing depressive disorders, pre-existing substance use disorders. And so if you can implement the use of standardized scales looking for those things, if a person flags high on any of those scales, that will also raise your level of awareness that this person will be at increased risk for developing an opioid use disorder in response to prescribed medications. And so maybe after that person checks in, you fill in the time that they're waiting in the lobby by having them fill out these scales. And the KJH is 4 questions, the PHQ-4 is 4 questions, that's for depression, the GAD-7 is 7 questions, that's for anxiety. All of these are available in the public domain. You can literally just Google it. So you can give that patient a 1-pager in the lobby, and then when they come back to the room, you have the PMDP that shows their prescription fill history, so you can make sure they're only getting their meds prescribed by you. You have their anxiety, their depression, and their substance abuse score to flag you that this person may be at increased risk and therefore require more risk mitigation strategies if you get to the point of prescribing opioid meds. While they're waiting in the exam room, maybe you can fill in that time with a pamphlet, right? And so one of the things we spend quite a lot of time, especially in primary care, is educating patients about what this diagnosis means, what are the risks and benefits of the treatments that I'm prescribing for you. And so if there was a pamphlet you could give them to read while they're already in the exam room waiting for you to come in, then when you come in, you can just ask if they have any questions or just dovetail on that pamphlet, as opposed to having to provide that education from scratch. An ideal pamphlet would identify the risk of opioid treatment. That helps you explain why I'm not choosing that and why I'm recommending these other things. Ideally, it would educate the patient on the difference between setting an absence of pain goal and setting a functional goal. So this goes back to that wellness arm where we really want to get away from saying our goal is to decrease your pain from 10 to 5, but rather to increase your function from you can't get out of the bed to you can walk downstairs, right? And then finally, educating them on why we will be doing urine drug screens, because sometimes patients can get offended if you try to give them a urine drug screen. So you want to get that education up front so they know why you're doing this and understand it as just part of the clinical process. Now, finally,
Dr. Harrison?
Yes.
We just have some questions in the chat box that I wondered if you wanted to take a little time to address now.
So do I see from Anita Coe? I can only see part of her question though. I am practicing in the Appalachian Mountains with limited resources. What is the rest of it?
Question is, about half of my patients do not have insurance, so resources are limited. I would benefit from more training. Can you recommend some resources or CME sources, etc.?
Sure, absolutely. So Substance Abuse Mental Health Services Administration, SAMHSA, SAMHSA, has awesome educational materials there that can talk to you about how to identify, how to manage if you're in a rural area and you don't have the support, but even also how to build that support network. And so I want to put a plug in here for technology. Now that telepsychiatry is like really booming, that allows us to reach into rural areas. So even if you could make a relationship with providers via that method, that would help. But SAMHSA definitely, and then ASAM, American Society for Addiction Medicine, will have a lot of great CMEs for you as well. The other thing I will say is you don't always need to refer to a psychiatrist, right? So as physicians, we kind of scale down our vision, and our referral sources are typically to other physicians. When it comes to this, you can absolutely feel comfortable referring to a counselor, a marriage family therapist, a clinical social worker, because they will typically have a network of psychiatrists that if that person needs additional psychiatric treatment above and beyond the mental health treatment they can provide, then they can get that person connected. Okay, Karen Palombo says, do you know how to access the resource you have identified? How or where? So definitely Google. If you're trying to build your referral network, a great resource is actually psychologytoday.com. So that's therapists listed all over the world. You can screen it down by telemedicine. You can screen it down by expertise in substance abuse. You can screen it down by your geographic area. You can reduce it for people that accept insurance, people that don't accept insurance. And that can be the beginning of building your referral network so that you can have these things in place to give a warm handoff for your patients. NCPC participant 7, is cannabis a useful tool to help with pain relief and treatment of chronic pain? So there's definitely an evidence base for the treatment of chronic pain with marijuana. The issue is that marijuana also is addictive, right? So while it has a lower addictive index than, say, an opioid or narcotic pain medicine, the risk for addiction is still there. So if you've done your risk analysis with the substance abuse screen, the depression screen, the anxiety screen, if they flag on any of those, then just like your radar has to be up for them abusing an opiate pain medication, your radar has to be up for them abusing a cannabis recommendation. One of my issues is when a patient tests positive for marijuana. I can't see the rest of the question. NC participant 21.
It says, some of my partners are okay with giving narcotics to, but I do not feel comfortable with this. Is it legal in Alaska?
Oh, so I don't know specifically about Alaska's medical marijuana laws, but if that person, but I do know that Alaska does not have recreational marijuana laws as legal. So if that person has not gotten a prescription for marijuana, the marijuana in their urine is considered illegal. The first thing that you do is really have a conversation. I'm an addiction psychiatrist, so the position that I take is if I'm prescribing you a narcotic pain med, you cannot use any other illicit substance, period. And I will be drug screening you regularly because I'm mitigating the risk of abuse. The issue is that if they're abusing one substance, their addiction pathway in the brain is primed for getting addicted to other substances, and so you want to try to mitigate that risk. And so I actually agree with you more so than with your partners when I screen, and it's not an automatic cutoff, right? But it is that if marijuana is not a problem for you, you will be able to stop smoking it. So let's give you an opportunity to do that. Or if you feel like marijuana is more effective for your pain than narcotics, someone else who's qualified to manage that for you can do that, but we won't be doing both at the same time. And it's a difficult conversation, especially if there's a, that's actually one of the barriers too, is the split among partners in the same practice. You really want to try to execute protocols and have procedures that govern you guys all being on the same page. Otherwise, you just open up a split with you and your partners. But the absolute safest recommendation there is no positive drug screens of any kind for anything that I have not prescribed for you.
Thank you, Dr. Harrison. We are running a little short on time, so I think we should probably move through your slides and hold some questions for now.
Sure. So in the checkout is then, of course, when you want to have your front desk help people access your referral resources. When we talk about resources as a barrier, this really splits into practice resources and patient resources. So we address some of these in the questions, right? They're geographical barriers. Insurance coverage is a barrier. Lack of a referral network is a barrier. So you plan for those as much as you can in advance. I already mentioned technology. Also, the public mental health system often doesn't integrate well with the public physical health system, but we're going to have to start building those connections so that we can float people between and have adequate communication to undermine risk. And then patient resources equal, can they afford to fill the prescriptions? Do they really understand the risk and benefits? We try to get at that with handouts. Any other barriers? Can they get to the clinic? Can they, we ask them to go take a walk. Do they live in a neighborhood where they can take a walk? And so it's really just being aware of those barriers and trying to make a plan for them. And then the final is knowledge. So this also came through the questions, right? Like, where can I get a CME? Honestly, there are so many online CMEs, and they're pretty good. I float around the online CMEs quite a bit. If you Google exactly what you're looking for and put CME, you can typically find free online CMEs. and access them that way, but your professional, like your state psychiatric association, the American Psychiatric Association, the American Association for Addiction Medicine, all of those will be great resources. I encourage you, as you're trying to implement these guidelines, to really look at these three main topics for your CMEs. So what are the non-pharmacological interventions for chronic pain? Those with great data are exercise, CBT, and interventional procedures. So if you concentrate your CME over the next few months in those buckets, you'll be preparing yourself to implement these guidelines. In terms of functional planning, that's really not how we're trained as physicians for the most part, right? We're trained to measure symptoms and get symptoms to go to zero. So when we're asking for a paradigm shift from managing pain to 0 to managing function to 100, we really need to learn how to do that. There's a lot of great resources. Again, you can Google functional treatment planning CME, and you'll see tons of options come up. And then finally, naloxone for overdose prevention. This is huge. You can prescribe naloxone both to the patient but also to the support system. So if you think a patient is at risk for overdose, either because of opioid use disorder, or maybe you've had to use concomitant long-acting and short-acting opiates, or maybe they're also prescribed a benzo, all of those things that are described to increase risk, then you may want to consider giving a naloxone prescription to that patient, but also to their support system, because if they're overdosed, it will be somebody in their support system that actually gives them the naloxone. And so that was all of my slides. If we had time for more Q&A, I'll leave that to Dr. Gagliotti to take us to the next step. I hope that was helpful.
Thank you, Dr. Harrison. That was extremely helpful. And unfortunately, we do not have time at this time to take any more questions. We will go to Mr. Langford, but I encourage you to continue asking questions in the chat box. And Dr. Harrison, if you want to address some of those questions in the chat box, that would be great as well.
Okay.
Mr. Langford.
Hello. Can you hear me?
We can.
Good. Okay. Thank you for having me today. I appreciate it very much. I'm going to talk about the opioid crisis and tell you a little bit about what we're doing as a prevention organization, the Georgia Prevention Project, how we got started and what we do. And so it's not quite addressing the opioid guidelines from CDC in the same kind of detail that Dr. Harrison did. But at least I'll be able to give you a little bit of a broader perspective on some of the problems that are associated with the opioid problem and the opioid crisis, and a little bit about what we're doing here in Georgia. And I'm going to start with a few slides right off the bat that just sort of show you the magnitude of the problem that we're dealing with. Some of you may have seen these slides at some point in the recent past, but I'm going to put them up here anyway. You see this Georgia overdose death chart here, accidental, intentional, and undetermined. The accidental rate has been climbing steadily, and in the past couple of years it started to take a sharper turn. If you look at drug overdose deaths versus car crashes, those lines crossed in 2014, so that we now have more drug overdose deaths than car crashes in Georgia. That's also true nationally. And if you look at this number in 2014, then what we're looking at is about 100 of these overdose deaths a month, which means about 25 a week. And so, pretty significant problem. And as you can see, it's getting worse. It just keeps climbing. And this shows it even more dramatically in terms of how that spike has happened, particularly since 2013. But this steady growth, this steady curve with a couple of dips, but a pretty steady upward movement of pain reliever related deaths, and those also versus heroin. And you see the heroin piece in there is the little red line in there, and you can see that is growing. What we know is that 80% of heroin users say that they got there. They became addicted to heroin by first becoming addicted to opiate pain relievers. So it's a significant problem. One other thing you'll note there, and that's that spike, and why don't we have data from 2015 yet? The data from 2014 actually just came in the past few weeks, so there is some lag there about the data, and that's not a good thing. A lot of folks are working on these data issues to try to get faster data, to get data to us more quickly, and especially since we're dealing with something that we can call an epidemic, where those spikes are going higher and higher, and they're getting there so fast we can't really even keep up with it on a good data basis. Now, if you look at death rates related to ages, then you might have seen some of these figures in the news more recently too. That age bracket 45 to 54 climbing steadily and outpacing these other areas. The age group 25 to 34, that red line spiking 2013 to 2014. We think that's related to heroin. Those two of those lines spiking, not a good sign at all. And so we think these are related to overdose deaths. A couple of those lines may be related to long-term use of methamphetamine. That's one of the things that we've been working on for some time, and that's meth-related problems and deaths and addiction. And meth, you don't get the overdoses in the same way that you do with heroin or the opiate pain relievers. Instead, you get a long, slow curve of death, meaning that meth affects the body and every organ in the body in a very negative way, and people just die because their organs wear out. So that may be what's related to some of these lines as well. If you look at what we do, it's very simple. We focus on prevention, meaning we're not a treatment or recovery organization. We focus on the prevention side, so that we try to get to people, or teens in particular, and young adults, before they become addicted. It's cheaper and easier that way to do that. You're saving lives, you're saving costs, you're saving all kinds of things across a number of different categories by focusing on that. We do that through awareness campaigns, educational programming, strategic partnerships. I'll go into some detail about what some of those are. Our mission, we started as the Georgia Meth Project. I'll talk about that in a moment. So now we focus on meth, RX abuse, and heroin. Youth, particularly 12 to 17 years old, young adults, 18 to 24, and now particularly with RX abuse, we focus a lot on parents and the conversations that we have with parents. We started as the Georgia Meth Project in year 2009 and 10. Major media campaign in 2010. We brought to Georgia a campaign that was very successful in some western states, Montana, Idaho, Wyoming, Arizona, Colorado, and Hawaii. We were the only state east of the Rockies to really implement this kind of program. Very heavy media campaign focus. We were very lucky that a man named Tom Siebel, who had made a lot of money in the technology world, invested $30 million of his own money creating really fabulous materials, Hollywood produced and directed advertising, radio spots, all kinds of things that we could then take and implement here in Georgia. And all we had to pay was a very small licensing fee to make that happen. We did have to go and raise all of our own money to make that happen, and we did that through almost all private sources of income. And we've had some very good success in the meth arena that I could go into if someone wants to know more about that. The RX abuse program, we moved into RX abuse prevention work in 2014 after being asked by people in education, law enforcement, a number of places ask us to do that because they saw the problem beginning to show up even in middle schools and also in high schools. We see that 12 to 17-year-olds abuse prescription drugs more than ecstasy, crack, cocaine, heroin, and meth combined. Hard to imagine that. So every day, 2,000 teenagers use a prescription drug to get high for the first time. 70% of those say that they got these drugs from family members and friends, not prescribed for them at all. 8 million Americans are abusing prescription drugs. Heroin users, the average heroin user is a 23-year-old male. They transition from snorting pills to snorting heroin. And again, it's because of this use of these opiates they find that heroin's just cheaper than going and trying to pay somebody for the pills. Heroin today, much stronger than heroin was in the 1920s or 30s or even the 1960s. Much more powerful. Coming from Mexico now, not from Southeast Asia like it was previously. Because it's coming from Mexico, it's not being cut up, it's not being reduced, it's not being diluted. It's coming in a much stronger form than before. So, and again, these opiate painkillers like oxycodone, hydrocodone, they produce a high that's very similar to heroin. If you look at how these heroin addiction addicts got started, they will tell you 80% of them will say they got started with opiate-based prescription painkillers. Again, they moved to the heroin because it's cheaper and it gives them a similar type of high. We expanded our work again in 2014. We found some interesting survey results when we first got started. 23% of teens used a prescription drug that was not prescribed for them at least once in their lives, and 75% of those say they were 14 years of age or younger when they first used a drug that way. It usually means that a parent gave them the drug. It may have been prescribed. The parent might have been prescribed something for an operation. A typical way that these are prescribed. I had a nose and throat operation 2 years ago. The doctor gave me 60 pills. I needed about 3 or 4. Used 3 or 4. And here I'm sitting with a number that I don't need. That is very typical. So those sit in the medicine cabinet until a teenager, somebody else, maybe a family member, someone else, sometimes even a friend of a teen in your house might come and figure out, oh, that adult had an operation recently, had an injury of some kind. Maybe they've got some painkillers. And so they'll actually go through medicine cabinets and find those. So it's a pretty dangerous situation with these painkillers out there with no control. And in some cases, you've got a parent acting as a prescriber, essentially, where Bobby got hurt at football practice. Oh, I think I'll take some of the painkillers that were prescribed for me, and I'll give them to my child. Happens every day. There's a lot of that going on. So we've got to educate parents about this problem as well. We have school outreach programs. That's one of the things that we do. Since 2011, we've taught substance abuse prevention to over 120,000 students now in 250 schools in 70 counties in Georgia. We've now created a RX abuse lesson that's like one that we call a meth prevention lesson. And we have a full range, of course, of other modules that we call a substance abuse prevention course for educators. These teachers can actually earn a professional learning unit by taking all 4 of the modules that we have, if they've worked that out with their administrators at those different school systems. Or they can take these a la carte. They can say, no, I just need this RX abuse lesson for the class that I'm teaching this week, and that's fine. They can download that and use that. It's actually an online lesson. The meth prevention lesson and the RX abuse lessons are online lessons that they can use in the classroom with kids. And when they use those, we can tell which school system is it that they're using, how many kids are in the room, who's the teacher. We'll know all that information on a daily basis. So we're able to track how well we're doing with regard to putting these educational programs out there in the communities. We also have a college partnership program with 7 colleges and universities. We're expanding that now very quickly. College students trained in substance abuse prevention. So we actually go on the campuses and create a little core of students who are going to help implement that program on those campuses themselves. And they come up with some pretty creative strategies to tackle RX abuse on campuses. Here are just a couple of examples of some of those, and where we hand out the T-shirts, do some of those things. On the back of that bus, this is at the University of Georgia, where it has a beer and it has a pill bottle, and it says, honey, we're just not meant to be together. So dogstakeasdirected.org. So this is a local campaign. Sounds kind of cute. Well, college students created that campaign. College students are responding to it. And so, we think that's a pretty effective way to make things happen on some of these campuses. Let the college students help run the programs. Those are at several colleges today. Again, we're trying to expand those and do so as quickly as we can. We just started this program just in the past 12 months, and we're moving quickly as we can. And you can see that list there: University of Georgia, Kennesaw, Georgia State, Georgia Tech, West Georgia, Oxford College at Emory, and Georgia Southern. We've also created something else interesting in the past 6 or 8 months, and it took actually probably a year and a half to get there, but our first 2 meetings were just since January. A Substance Abuse Research Alliance. We call that SARA. It's researchers and practitioners in substance abuse. And this means doing 3 things with this group of people. Coordinating research by identifying urgencies and gaps in the research documentation that's out there, supporting research through data and grants. Data is not always as good as we'd like for it to be. There are lags in the data all the time. Influencing and informing public policy. That means helping legislators, governors, state agencies, those kinds of folks as they move forward with public policy and new public policy. We have about 50 people involved in this alliance so far. Pretty exciting stuff. Lots of professors, schools of public health all across Georgia. Here's a list of some of those groups. It includes Augusta University.
Mr. Langford.
Yes. Hello?
Mr. Langford, we're just running a little bit short on time, and I'm hopeful that we can take some questions from the group soon.
You bet. Anytime. Ready to do that now. I put these last 2 slides in here just as ways to show you what we do when we have community programs, action steps, what do parents need to do, what do people in the community need to do, and these are some of those steps. Glad to take any questions.
Thank you so much about talking about your experiences with the community. That was an incredibly helpful perspective. Does anyone have any questions for Mr. Langford? I see one. How can we utilize these community-based strategies to enhance our work and practice?
Well, I think that a community, and you may see this in smaller communities today. You're certainly seeing it in the Atlanta area. Where the communities are coming forward and saying, "Whoa, we've got a problem," and law enforcement people are saying that, parents are saying that, people in schools are saying that. Some people may be in denial, but a number of people want some help, and I think they need help from a number of sources, and I think that includes doctors. I think doctors need to come to the table when there are community forums and participate in those forums and act as a good resource so that there's not information floating around out there that's rumor. We need good experts at the table, and doctors provide expert information.
Dr. Harrison, anything to add?
Just that I couldn't agree with that more. I did look through some of the other questions, so I sent an answer that I hope to answer that for some people. They asked me to write out the resources, and it was function-based treatment planning. I saw one, and this last question also gets at that, any effort to educate surgeons. So we absolutely, the other question was like, my difficulty is when specialists start the prescription and how do I inherit the person, and then it's, a difficult time. So we really need to get to surgeons and emergency rooms and dentists and inpatient units, our hospitalists, so that we can kind of be, like Mr. Langford was saying, that unified physician voice, all following these guidelines, because although these are directed at primary care for chronic pain management starts acutely so often, and then we're trying to figure it out on the outset. So I think those efforts will be coming, and we'll certainly be participating in those.
I want to throw
I
in
will
one
say that, please, Mr. Langford.
I just want to throw in one piece of information that I think might be helpful. I just came from a lunch meeting where we brought in a man that everybody needs to know and get to know his book. His name is Sam Quinones. That's spelled Quinones. Sam Quinones. The book is called Dreamland. It's a book about how we got to where we are with regard to the opioid crisis in this country and how it led to the heroin problem that we have. Great book. He was one of the people who was one of the people on the Frontline series Chasing Heroin, the documentary they did a couple of months ago. Quite good, and gives terrific in-depth information about where we are and where we should be and where we should be going. I just wanted to throw that in there as a Dreamland's the name of the book by Sam Quinones.
Thank you. That's a great resource. I will also just mention the JAMA article that came out as an accompaniment to the CDC guidelines in the March 2016 issue, and I did put a link to the article in the chat comments. And they do address some of those things that Dr. Harrison was talking about, you know, presenting a united front as physicians, and specifically speak to the fact that emergency room physicians and specialists certainly play a frontline role in these issues as well. So I think that's a great and sort of nuanced article if anyone is looking for a good in-depth but concise read on this topic.
I see the question, and it was here twice, but this last one is by Mario Mendoza. Do you see a role for abuse-deterrent opioids as part of a multi-pronged approach to prescription opioid abuse? And so that's what we've all been taught, right? We have these opioids that are packaged as longer acting, don't come on us quickly, all of those things that reduce the attractiveness for medication for overdose, for abuse and intoxication. And so historically, we did want to reach for those longer acting opioids in the higher risk population, thinking that we were mitigating those risks. What these CDC guidelines have shown us from the literature review is that while we think that they're mitigating abuse risk, there's no systematic, robust literature to prove that to us. But there is a systematic, robust literature to prove to us that longer acting opioids are increasing the risk of overdose. So we may not be getting the benefit from them that we thought. We're definitely getting the risk of building blood levels, especially if they start to abuse them, and then respiratory depression and overdose. And so I would say, if you justify that and you're using a longer acting because you want to, decrease the peak and decrease the onset of the intoxication to minimize the risk of withdrawal, you absolutely 100% want to also prescribe naloxone and document that you have given that person education about overdose risk.
We have another question from Mario Mendoza. Any comments on a daily morphine milligram equivalence as a risk mitigation strategy?
Sure. So the CDC guideline actually goes in great detail about this, which I really appreciated. And so if you exceed that threshold for daily morphine milligram equivalence, and I'm sorry, I can't call the number off the top of my head. I think that
I believe it's 50.
Yeah, okay, I was going to say 50, so we both think it's 50. So 50 morphine milligram equivalents is where your overdose risk starts to skyrocket, especially if you're prescribing long-acting plus short-acting, especially if they also have benzodiazepine on board for some other reason, especially if they have some hepatic condition that can slow down the metabolism of their opioid medication. In all of those instances, you want to, try to stay under the threshold, but if you have to go above it, document, and without question, prescribe naloxone to that person and educate their support system about their risk of overdose.
Mr. Langford, I see a question that you might be able to answer in the chat box here from Thomas Minich, asking about any data regarding teens smoking hydrocodone in e-cigarettes.
I saw that question, and I haven't heard of any of that, either anecdotally or otherwise. They're using hydrocodone. They're using all these opiates in a variety of ways. I mean, pill form is one, snorting is another. Certainly, they're trying to smoke those, smoke it as well. So they'll try just about anything, like they will with methamphetamine, to get it into the body if they think they'll get a better high out. I have not seen that about e-cigarettes. I certainly will keep an eye out for it, but I don't think that that's as big a problem as it is just the general availability of these opiates out there, and kids, having access to them in a variety of forms.
Thank you. And Dr. Harrison, there's a question about Imodium. I think there was an article today in the lay press about Imodium use as a treatment for withdrawal or use when opioids aren't available today, and I think it was in the New York Times, I'm not certain. The question is from President Obama. I'm not sure if you can see the text there.
So welcome to the call, President Obama. Speaking with Imodium, which is loperamide. So loperamide does have opioid action. It also has central dopamine antagonistic action. And so loperamide has been coming on the scene as a drug of abuse. So I think this is the corollary to what we saw with cough medicine that had codeine in it, and then cough medicine that kids were abusing at super high doses that had dextromethorphan, and why these things are having to go behind the counter. So I think this is probably the beginning of what we will start seeing, and it's the direct result of, like Mr. Langford was saying, how the transition is kind of from prescription opioids, and then those become too expensive, and so heroin is less expensive, but then heroin may become unavailable. Imodium will always be available because it's just there in the drugstore. So we do have to keep our eyes out for that. That's not going to show up in your garden variety urine drug screen. So it's probably just a question that you have to ask. And if you, look at the PMDP, and perhaps you can see it being just prescribed at higher than over-the-counter doses. But that will be a difficult one to get our hands around, just because it's not easily measured right now. But it seems like it is on the rise.
Thank you. And I think we have one more clarifying question from Mario Mendoza. It's the second question in the chat box. He said, thank you. The question is, when do you have to use an opioid? Then when you do have to use an opioid, then should you use an abuse deterrent opioid?
Okay, so it seems like the answer should just be yes, and that's what we originally thought, right? So it's like, especially if a person had some other risk factor, a history of a substance use disorder, anxiety, depression, chronic stressors, then it would be, yes, you definitely want to use an abuse deterrent opioid to decrease their risk of getting addicted. The issue is that the abuse deterrent opioids are long-acting opioids, and the recommendation is for immediate release opioids to reduce the risk of overdose. So and the data about abuse deterrent opioids is not solid. We don't know for sure that we're deterring abuse. And so the recommendation from these guidelines is just go for the immediate release, because you're mitigating your risk of overdose, and there's not even clear evidence to show that there's any higher risk of abuse with them.
One other comment on that I heard. I heard a comment on that subject today from Sam Quinones, and he says that there's actually a lawsuit in California against one of the manufacturers of the opioids that had the long-lasting or supposedly abuse-deterrent opioid. And what they were advertising is that these were 12-hour pills. But in reality, the pills were only working for 8 hours, which means that during that interim period from the 8th hour to the 12th hour was the worst thing on the body in terms of experiencing the negative effects, the withdrawal effects, which then created these waves of need and satisfying those needs that led to more addiction. So I think you probably should watch out and be sure that these longer term or longer acting opioids are really doing what they say they're going to do. Are they really a 12-hour pill, or is there something less than that? And then how do you put a second pill right behind that or not? So it's just something to watch out for. You may hear more about that in the near future.
Sure, and I'll just piggyback on that. The risk for overdoses, because the pain effects of that long-acting pill may wear off before the respiratory depressant effects. And so if they take another pill before those have worn off because they're having pain or withdrawal symptoms, that's increasing the risk for respiratory depression. And that's most likely why the overdose risk is higher with the long-acting than it is with the immediate.
Right.
Thank you both so much. I think that our time is gotten short here today. But thank you all participating for your wonderful questions. A lot of folks have asked if this recording is going to be available for use afterwards, and I would say that both the recording and the slides will be available for your use afterwards, and I believe you will get an email with a link to that information. Dr. Harrison and Mr. Langford, thank you so much for your time and your expertise in this area. We have really benefited from learning from you today. And this last slide here just has a few links to a quick fact sheets, and then there's some links as well provided in the chat box, and certainly referenced in the other slide set as well. So thank you all for your attention, and we really appreciate your participation today.
Thank you for having me. Enjoyed being part of the program.
Thank you.